Hello, everyone, and welcome to the very first episode of EP Edge Journal Watch, your bi-weekly deep dive into the latest evidence shaping the future of cardiac electrophysiology. I'm Dr. Niraj Sharma, and in this series, we're not just summarizing data, we're distilling the studies that actually change how we practice EP. Each issue will break down high-impact articles, analyze their strengths and limitations, and talk about what they mean in the real world, in our EP labs, clinics, and patient encounters. Today's episode features 3 studies that touch on very different but deeply interconnected areas of cardiovascular care. 1. De-escalation of heart failure therapy after successful AF ablation. 2. A simple but powerful electrolyte intervention to reduce arrhythmia burden. 3. How pregnancy outcomes decades earlier can influence AF risk. Let's dive in. The first article, GDMT, or Guideline-Directed Medical Treatment Withdrawal After EF Recovery Post-AF Ablation. This is a study published in Open Heart 2025 by Al Aidarous and colleagues. This is an elegant multi-center UK cohort study of 88 patients who presented with tachycardia-induced cardiomyopathy due to atrial fibrillation, that familiar phenotype of reduced ejection fraction, dilated LV, but no significant structural disease. All patients underwent AF ablation and achieved EF recovery to 50% or higher. Here's the key question. Do these patients really need to stay on guideline-directed medical therapy indefinitely once their LV function normalizes? 57% continued GDMT. 43% withdrew at least half their HF meds. After about 32 months, EF remained stable in both groups, 56.3% versus 56.8%. Relapse was rare, just around 2% in each group. LV dimension stayed stable and sinus rhythm was well maintained in more than 80% of patients. That's a remarkable observation because what we often do in practice and what guidelines have long encouraged is indefinite continuation of GDMT, especially beta blockers and RAS inhibitors, even when EF recovers. But this study suggests that in carefully selected patients with arrhythmia-induced cardiomyopathy, durable rhythm control itself may be sufficient to maintain left ventricular recovery. My take: as electrophysiologists, we see this all the time. A patient with persistent AF, tachycardia-induced LV dysfunction, undergoes ablation, and 6 months later, the EF is normal. The reflex is to keep the patient on beta blockers, ACE inhibitors, maybe an MRA, because that's what we do in heart failure with reduced EF. But this population isn't the same as non-ischemic or ischemic cardiomyopathy. What this study does is start a conversation about de-escalation, not reckless withdrawal, but personalized care. This trial has the following strengths. 1. Real-world, multi-center design. 2. Robust imaging and follow-up. 3. A uniquely focused population, distinct from traditional heart failure cohorts like TREAD-HF. Before we move on, it's worth putting this into context with the TREAD-HF trial published in The Lancet back in 2019. TREAD-HF looked at patients with previously reduced ejection fraction who had fully recovered on guideline-directed therapy. These were mostly non-ischemic dilated cardiomyopathy patients. When GDMT was withdrawn, nearly half relapsed within 6 months, even though they initially felt well and had normal imaging and biomarkers. That was a big turning point. It proved that recovered EF is not the same as cured heart failure. But here's the nuance. Those patients still had an underlying cardiomyopathic substrate. In AF-induced cardiomyopathy, once the arrhythmia is successfully treated, the substrate may be far less persistent. That's why the new study by Al Aidarous and colleagues is so intriguing. It suggests that tachycardia-induced cardiomyopathy might behave differently from the TREAD-HF population, and selective GDMT de-escalation may actually be feasible in some of these patients. What are the limitations of this trial? 1. Non-randomized, so there's selection bias. 2. Modest sample size, 88 patients. 3. Predominantly male cohort, which may limit generalizability. 4. And while follow-up was over 2 years, late relapse could still occur. What are the clinical implications of this trial? This trial doesn't mean we should stop GDMT in every patient with recovered EF, but it does mean that tachycardia-induced cardiomyopathy may not behave like other heart failure with reduced EF phenotypes. It opens the door to structured withdrawal protocols, careful echo follow-up, and patient-specific decision-making. And perhaps most importantly, it reminds us that curing the trigger, in this case AF, can sometimes be more powerful than just treating the consequence. The second article, Targeting High Normal Potassium to Reduce Ventricular Arrhythmias, published in the New England Journal of Medicine, 2025, authored by Yons et al., also known as the POTCAST trial. Now, this is one of those trials that makes you think, why haven't we been doing this all along? 1,200 ICD recipients with baseline potassium at or below 4.3 millimoles per liter were enrolled. Participants were randomized to either standard care or an active intervention that titrated potassium into the high normal range of 4.5 to 5.0 millimoles per liter. The intervention wasn't fancy. It involved potassium supplements, mineralocorticoid receptor antagonists, or both, combined with dietary guidance. Simple, scalable tools. Median follow-up was about 40 months. The primary endpoint, a composite of VT, appropriate ICD therapy, arrhythmia or heart failure hospitalization or death occurred in 22.7% of the high normal potassium group compared with 29.2% in standard care. That's a hazard ratio of 0.76, and the number needed to treat was just 12 patients to prevent one major event. And here's the kicker: no excess hyperkalemia hospitalizations. So it's not just effective, it's safe. This is my take as EPs. We fine-tune antiarrhythmics, optimize device therapies, and chase scar borders on mapping systems. But something as basic as potassium can sometimes make a bigger difference than another fancy algorithm. We've long known that both hypokalemia and low normal potassium increase arrhythmia risk. This trial provides hard, prospective evidence that pushing potassium just a bit higher safely reduces real arrhythmic events. Strengths of the trial include 1. Large randomized trial with clinically meaningful endpoints. 2. Pragmatic and scalable intervention. 3. ICD therapies as a surrogate for arrhythmia burden. A robust, objective endpoint. Limitations: 1. Open label design. 2. Not all patients reach the target potassium range. 3. Applicability to non-ICD populations is still uncertain. Clinical implication of the trial: this is the kind of intervention that can be implemented tomorrow in EP and HF clinics. It's low cost, evidence-based, and directly tied to arrhythmia risk. In my view, potassium targeting should become a standard part of ICD follow-up protocols, particularly for patients with borderline K+ levels and high arrhythmic burden. The third and final article, Adverse Pregnancy Outcomes and Long-Term AF Risk. This study was published in JAMA Cardiology 2025, authored by Crump et al. This is a landmark population-based cohort from Sweden, over 2.2 million women with follow-up spanning up to 46 years. More than 51,000 developed atrial fibrillation, with a median age at diagnosis of 63. Here's what they found. Women with adverse pregnancy outcomes, including preterm delivery, preeclampsia, hypertensive disorders, gestational diabetes, and large for gestational age infants, had a significantly increased risk of AF later in life. The hazard ratios ranged from 1.11 to 1.44. And importantly, these associations persisted for decades after delivery. And through co-sibling analyses, the authors showed the findings were largely independent of genetic or familial confounding. This is my take. This is a powerful reminder that AF risk doesn't start at age 60. For many women, it may be programmed during or even before pregnancy. Pregnancy is essentially a physiologic stress test, revealing latent cardiovascular risk. We should be integrating adverse pregnancy outcomes history into AF risk assessment and prevention strategies, just like we consider hypertension, sleep apnea, or obesity. The strengths of the trial include 1. Massive cohort with decades-long follow-up. 2. High-quality national registry data. Third, co-sibling analysis to reduce confounding. Limitations of the study are 1. Observational design, so no causality. 2. Limited physiologic data to explain the mechanisms. Third, AF ascertainment based on registry coding. Clinical implications are extensive. This study expands how we think about AF risk in women. If a woman has a history of preeclampsia or preterm birth, we should be flagging her for early surveillance and lifestyle intervention long before the first AF episode. This issue of EP Edge Journal Watch highlights are 1. Reassessing who really needs lifelong heart failure therapy after AF ablation. 2. Using potassium as an arrhythmia prevention tool, not just a lab value. 3. Recognizing that AF risk begins long before we think, sometimes as early as pregnancy. If you'd like to dive deeper into these studies, including trial links, references, and figures, check out the EP Edge newsletter on LinkedIn. And don't forget, and this Journal Watch series is now available as a podcast, so you can stay up to date even between cases and consults. Thank you for tuning in to this first episode of EP Edge Journal Watch. Until next time, this is Dr. Niraj Sharma. Bye for now.